it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was: my mum is in ICU with tracheostomy and whilst being weaned off the ventilator, how can I keep my mum in ICU despite their plans to send her to LTAC? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer a question that we get quite frequently as part of my one-on-one consulting and advocacy service here for families in intensive care. So today's question is why freezing people after cardiac arrest can save lives. So let's dive into it. How devastating to think that someone is on the brink of losing one's life. It could be much worse if you know they are still alive but in a state of a coma and can never tell their fate. Or, God forbid, having lost someone you love because of a sudden cardiac arrest. Clinical studies and innovations nowadays are evolving each time so that most people's lives can be saved. Cardiac arrest is one of the most common and devastating cardiac and neurological emergency affecting most of the people worldwide. Most of them are being successfully resuscitated but then didn't survive in the hospital or are left with severe brain injuries during the heart attack. Cardiac arrest is the sudden stopping of the heart. When the heart stops, so does the flow of blood and oxygen to the brain. That lack of oxygen and blood can cause brain damage. The longer the heart goes without beating, the greater the chance for permanent brain injury or even death. If these people are not resuscitated, brain cells begin to be irreversibly damaged and subsequently the person dies. After resuscitation, treatment within the first few hours is critical for avoiding or limiting brain damage, and one of which is the cooling therapy or therapeutic hypothermia. So why might your loved one need therapeutic hypothermia after cardiac arrest? Very good question. Therapeutic hypothermia can help only some people who have had a cardiac arrest. Some people regain consciousness right after cardiac arrest. These people often don't need this procedure. It is helpful only for people whose heartbeat returns after a sudden cardiac arrest. If the heartbeat doesn't restart soon, it won't help. Therapeutic hypothermia can be a good choice if the heart restarted, but you are still not responsive. It can raise the chances that you will wake up. So here are some recommendations. For patients who are comatose in whom the initial cardiac rhythm is either pulseless ventricular tachycardia, also known as VT, or ventricular fibrillation, also known as VF, after out-of-hospital cardiac arrest, therapeutic hypothermia, 32 to 34 degrees Celsius, for 24 hours is highly likely to be effective in improving functional neurological outcome and survival compared with non-therapeutic hypothermia and should be offered. And that's also referred to as level A. For patients who are comatose in whom the initial cardiac rhythm is either VT, ventricular tachycardia, VF, ventricular fibrillation, or asystole, pulseless electrical activity, also known as PEA, after out-of-hospital cardiac arrest, targeted temperature management is 36 degrees Celsius for 24 hours, followed by 8 hours of rewarming to 37 degrees Celsius and temperature maintenance below 37.5 degrees Celsius until 72 hours. And that's as likely as effective as therapeutic hypothermia and is an acceptable alternative, and that's referred to as level B. Next, for patients who are comatose with an initial rhythm of PEA, pulseless electrical activity, asystole, Therapeutic hypothermia possibly improves survival and functional neurological outcome at discharge levels versus standard care and may be offered. And that's referred to as level C. Next, pre-hospital cooling as an adjunct to therapeutic hypothermia is highly likely to be ineffective in further improving neurological outcome and survival and should not be offered. Studies found strong evidence that for patients who are treated with electric shocks to the heart, also known as defibrillation, after out-of-hospital cardiac arrest, and who are in a coma, cooling the body down to 32 to 34 degrees Celsius or 89.6 to 93.2 degrees Fahrenheit for 24 hours, which is called therapeutic hypothermia, is effective in improving their chance of recovering brain function. It also found moderate evidence that keeping the body cooled down to 96.8 degrees Fahrenheit or 36 degrees Celsius for 24 hours, followed by rewarming to 99.5 degrees Fahrenheit or 37.5 degrees Celsius over 8 hours, which is called targeted temperature management. It's also effective at helping reduce brain injury after cardiac arrest. So the next question is really, what happens during therapeutic hypothermia? Therapeutic hypothermia occurs in 3 phases: induction, maintenance, and rewarming. Clinicians must control hypothermia and rewarming to prevent potential adverse effects such as arrhythmias and skin breakdown during the cold phases, induction and maintenance, and rapid electrolyte shifts during the rewarming phase. Temperature should be monitored with a method that measures core temperature, such as use of an esophageal bladder or pulmonary artery catheter. Let's break it down further to, first of all, the induction phase. The goal of the induction phase is to get the patient to target body temperature as quickly as possible. Doing this may entail the use of ice packs, iced lavage, rapid cold fluid infusion, non-invasive cooling devices such as cooling blankets, wraps, or gel pads, or an intravascular catheter that circulates cold fluid in a closed loop within a large vein. A combination of rapid cold fluid infusion with a non-invasive gel pad system is used. This phase calls for sedation, which is also known as an induced coma, and neuromuscular blockade when the cooling process begins to prevent shivering during induction. This allows rapid cooling to target temperature. Next is the maintenance phase. During the maintenance phase, controlling the patient's temperature within the target range, usually 32 to 34 degrees Celsius, is crucial. This phase can last up to 24 hours from the time the target temperature is reached. This is depending often on facility or hospital protocol. Automated invasive and non-invasive methods can be used to keep the patient within range. These methods are much less labor-intensive than non-automated methods. Next is the rewarming phase. Temperature control remains important during rewarming. Warming the patient too quickly or allowing continued shivering causes dangerous electrolyte shifts, leading to potentially lethal arrhythmias. Controlled rewarming of 0.15 degrees to 0.5 degrees Celsius per hour is recommended. To maintain tight temperature control throughout rewarming, the protocol calls for a neuromuscular blockade. Because electrolytes shift out of the cells back into the serum during rewarming, frequent electrolyte monitoring is needed during this phase to prevent critically elevated levels. Slow, controlled rewarming allows the kidneys to excrete excess potassium, preventing hyperkalemia. The patient may become hypoglycemic during rewarming as the insulin resistance of earlier hypothermia phases diminishes. Glucose levels must be monitored frequently with insulin titration and dextrose boluses used as needed to maintain the patient within ordered ranges. Careful fluid monitoring during rewarming is crucial because of the vasodilation that accompanies a body temperature rise. Volume replacement may be needed to prevent fluid deficit and hypotension. So what are the risks of therapeutic hypothermia after cardiac arrest? Therapeutic hypothermia is very helpful for some people, but it has some rare risks. Some of these risks include another abnormal heart rhythm, especially slow heart rates, severe blood infections such as sepsis. Blood is less able to clot. This can cause bleeding. Electrolyte and metabolic problems, raised blood sugar levels. So what happens after therapeutic hypothermia after cardiac arrest? Patients will be in the intensive care unit and they will be carefully monitored by the ICU team. You may be on a ventilator to help with breathing. Patients most likely need a central line and an arterial line and may be started on inotropes or vasopressors to support body functions. An induced coma is generally required if one requires mechanical ventilation with a breathing tube. To be able to tolerate the breathing tube in their throat and an effective ventilation therapy would be nearly impossible to achieve. Paralyzing agents like cisatracurium or vecuronium are used during the course of this treatment, and as soon as your loved one's condition allows, after vital body functions have been regained, the patient will be brought out of the induced coma by reducing the sedation. This is often a gradual process and may take some time to wash off the medications in their system. It may take a few hours and sometimes a few days until your loved one is waking up. Some people do eventually wake up after therapeutic hypothermia. They may not have any lasting brain injuries. Others might have some problems with thinking. They will need extra therapy. Sometimes cardiac arrest may harm other organs like the kidneys. You will need follow-up care. Medical care will depend on the reason for the cardiac arrest and the degree of damage. Other health problems you have will also determine the care you need. You may need medicine, procedures, and physical therapy. Some people might need surgery for heart disease. Other people might need an automatic defibrillator. So if you're scrolling down below this video, you can also get the references to this article. And if you're watching this on YouTube, just click on the link below this video. That'll get you to our website where you can read the references to this article. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free instant impact report now by entering your email below. In your free instant impact report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free instant impact report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free instant impact report now by entering your email below. In your free instant impact report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions. Discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind the scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again in another update next week. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of the website at intensivecarehotline.com. Also, have a look at our ebook section, and you can also get one-on-one consulting and advocacy with me over the phone, via Skype and via email by clicking on the tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.